you want me to do it, or? She's got it. There we go. So it's a pleasure to be here, and it's really been a pleasure to listen to other organizations and people that are trying to survive and thrive in the new world of alternative payment models. Especially the opportunity to hear my former colleague, Dr. Wild, yesterday talk about some of the things CMS is doing. I'm going to ask you, though, to put CMS aside during this presentation. We'll touch it on a little bit, but I'm going to really focus on what's going on in the private payer market with relationship to all the alternative payment models as well as bundled payments. How many of you are currently engaged with a commercial payer? So when I'm saying these are not Medicare Advantage or Medicaid, for bundled payments. Okay, how about for Medicare Advantage? All right, so a few. How many of you are clinicians, physicians, and others? Okay, CFOs, finance? That helps me tailor my presentation. Care management infrastructure and the people that really make it all work. And how about who's in data? That's my new world. There you go, great. So I'm hoping I'll be able to touch upon a number of things that'll be of interest to all of you. I want to start by first introducing MPA Healthcare Solutions. We are an analytic firm founded by a physician 30 years ago. We've been working with CMS data for 30 years, so all the comments you've heard about how hard it is to work with CMS data, we will definitely second that position. More recently, we've been involved with systems that are integrating other data. So if you want to think about big data, things like data that comes out of your cost management and finance systems, electronic health record data, payer data, and other data that seems to be of import as we try to figure out how best to take care of our patients. And that's going to be the key of the things that I'm going to talk about today. The other thing I'd like you to focus on is that we're really talking about risk. We're talking about the transfer of risk for the care of our patients away from a health insurer, either partially or fully, to an entity. Might be a doctor, might be a group of doctors, might be a hospital. But that's the core of what this is about. It's a risk transfer. And it's a transfer of 4 different kinds of risk. And the reason I asked who was in the room was because we all look at risk a little bit differently. So I think the most important risk, and I started my career in patient safety and emergency medicine, is what's going to happen to the patients as we reform the system. We have an ethical responsibility to use our data, to use our experience, to inform CMS and payers about what happens when we transfer the risk to the people who are making the care decisions. You know, you decide not to readmit someone as an emergency physician because it's day 29. That may not necessarily be in the patient's best interest, but I can tell you that's going on across the country right now. So these are the kind of things that we always have to default back to, so it has to be about the patients. The next area to think about is clinical risk, and this is adverse outcomes. So I'll be presenting to you some data and some theories about how adverse outcomes and financial risk are associated. Your clinical risk as well, and then the financial risk. And when we think about this for the long term, how many of you thought about beyond decreasing readmissions? What are you thinking about now, if I ask?
So reducing the length of stay in SNFs.
Okay, so post-acute care.
And the appropriate discharge first place setting from discharge.
Great, so he was not a plant. The next thing I want to talk about is appropriateness. Thank you so much. So you haven't heard the word a lot, but when I was at CMS up until 2008, we were trying to figure out how to set targets based on appropriateness of care as opposed to utilization targets. Because there was an internal recognition that setting a case or a utilization rate for anything, I don't care if it's mastectomies, SNF utilization, length of stay, is okay when you get to a massive population. But when you're talking about the population in a given hospital, you know, that really is fraught with some issues. Because let's face it, some patients are sicker than others. Some patients are more obese. So attempting to do any of this without appropriate consideration of risk stratification in your population is fraught with errors. So I'm also going to touch upon, you know, appropriate length of stay. You won't hear me say decreased length of stay. Appropriate readmissions. We just heard our last speaker say they have readmission rates between 2 to 4%. Does anyone know what an appropriate readmission rate is for joint replacements? The only way you can figure that out is to look at the outcomes for your patients who you readmit and those you don't, who are similar. That research has not been done yet, needs to be done. In addition to that, we have to look at surgery timing. I do want to, as a warning to those of you that are thinking about BMI, I was a little surprised when people said they were basically turning patients away because their BMI was too high. Maybe that was a misinterpretation on my part. But there is the American with Disabilities Act, and I worry if you're a nonprofit organization and you are potentially discriminating against obese patients. So I really would recommend that when you think about BMI, think about it within the aspects of care management, preconditioning, as well as what you can do from a risk perspective to take better care of those patients. So that's my only comment on that. So again, now we'll go to the payer landscape, now that you've got the big picture. A lot of different slides over the last 2 days looking at the switch to alternative payment models, of which bundles are one. This is in your slides. It's also on the website for the Healthcare Payment Learning Action Network, which is, how many of you have heard about the LAN? Okay. I participated on one of the groups that was setting this methodology up. And the key was that in the room was every major health plan, professional societies, consumers as well. Consumer Reports was there in the first group. And CMS was aligning the private payers with their goals related to adoption of alternative payment models, bundles, and capitation. And I think that's important because we can't take our eye off the ball and just focus on our 65 and older population or our Medicare patients who are under 65 but who qualify. Really important to recognize that all of these things are important. I do want to point out the fact that if you look at the dividing line between Category 2, the green, and the kind of orangey brown, it's a really putrid color, by the way. I didn't pick it out, CMS did. Anything to the left of that line, my left, will not, or my left, my right, will not be considered an APM. So that takes out ACOs, care management, a lot of the things that people have been adopting. Those are ways to do this work. They are not the work. So this is how everyone's looking at how this is going to transition. Again, Medicare Advantage is much more engaged in this right now because they're under a lot of pressure to decrease their spending because, let's face it, many of them are publicly traded companies. They haven't done well on the exchanges. Medicare Advantage, and actually, I worked for Anthem, had more patients now in Medicare Advantage and in Medicaid and other government programs than they did in commercial. This is their business now. So also remember that 30% of Medicare beneficiaries are not in fee-for-service. They're being insured through Medicare Advantage. And that number's only going up, and the level of acuity of those patients is going up as well. So whatever you're doing around CJR, think about how you're going to expand that. And you will have those entities coming to you with contracts for next year, 2017, to do programs. How many of you have been approached by a Medicare Advantage program payer about CJR? Anybody yet? Okay, they're out there. The other thing to recognize is that that's not the only model. We have some that are mimicking CJR. They'll come in and say, this probably isn't a bad idea. You're spending a lot of time building the infrastructure for CJR. And while you do that, you need to think about it. But they're also coming up with some new other alternative models, such as prospective bundles. And the only thing that's limiting prospective bundles and the transfer of full risk is the infrastructure. And I think we heard that yesterday from a number of speakers kind of interwoven in their thoughts. And the reason that infrastructure is not ready is because of the claims processing system. Major payers are out there rejuvenating, retooling, and actually investing in new systems to move to a prospective payment system. The sooner they can download the risk and offload the risk for an increasingly old, sick population onto the provider community is in their best interest. So it's not going to be as incremental as we've seen with CMS. That's a prediction that I'll make. So you also have to think about prospective payments as well. So let's shift a little bit and think about the negotiation. We have the landscape now. People are going to come in this year and talking about adopting these models. I like to use this particular diagram to help us think clinically and also to think about risk. So how do you divide up care, be it either from a care perspective or from a finance perspective? everywhere we go, and all the systems that we work with, have to define an evidence-based required care. And I would assume that people have done that already. I mean, that's been in place. That's what you've heard about this morning. I mean, that's the care redesign. That's really getting to the place where, based on the expertise, the national level, and your internal experts, your orthopedic surgeons and others you've adopted. But you'll see that's a small part. And when you think about the amount of time you're going to put into this, I'll kind of make some recommendations about where to put your time. The individualized care really is the population health place. This is the place where you're going to say these patients have certain comorbidities. They're obese. They're a diabetic. They live alone. A number of other things that you're going to have to take into consideration, some of which you can mitigate and some you cannot. An A1C, for instance, you're not going to fix in a month preoperatively. You are also not going to fix the fact if they've got 5 comorbidities. You can optimize them, but those will still be there and bring risk into the equation. Then you have to think about warranty care. What does it now cost you, or what will it cost you in the future, to care for those patients who do have complications that are unavoidable? You know, there's things that are going to happen. The whole idea that there are never events, to any of us that are steeped in mathematics, we know that's not the case. There will always be readmissions, there will always be deaths, there will always be errors. We have to minimize them. But you're always going to have a cushion built in for the warranty care. This is also going to be, it needs to be risk adjusted too, so it has to be based on the particular patients. And then we get to what some people would call the black swan category. This is where you need a stop loss reinsurance. Random events happen randomly, cases go bad. I mean, this is one of the issues in OB with, you know, the normal pregnancy and a baby is born with multiple defects that weren't predicted or had multiple problems. That happens as well. So when we think about it from a financial perspective, this is a real convenient way to think about how you're going to divide up the dollars within a bundle. On the left side, what you'll see is that this does relate to routine care as well as care of complications. It stopped. It's not working. I'm hitting the down button, nothing's happening. Oh, there we go. Another area that you're going to face in negotiations is exclusions. And we heard yesterday that, you know, there's some ideas about excluding patients based on BMI or if they're a smoker or, you know, I don't know, by zip code potentially. I mean, there's different things that you might consider. And some of the early bundles that were done by employer groups or by others use this methodology. It's also something that seems really palatable to doctors. You know, we're only going to put in the bundle our healthy patients. Has anyone heard that? We don't want any of the sick patients in? Big mistake, and I'll talk a little bit about that, because the fact is the area where you're going to be able to reduce cost isn't going to be in your healthy patients. If you're thinking about reducing risk or reducing cost, those aren't the folks driving your cost. So please recall that when you're in these negotiations, that when you think about it, both with the payers and with your internal physicians and others, that you want to really limit exclusions to things that are going to be a primary problem in and of themselves. So things like a patient with renal failure. I mean, this one is the perfect example, I think. Someone who's on dialysis. That problem far outweighs anything related to, you know, the joint replacement. So it's going to overwhelm it. So that might be a population you would exclude. Does that one make sense? Seem to make sense to everybody? Good. If my examples don't hit the mark, I can always try a second one. And it's also something that's high risk and occurs rarely enough that there's insufficient volume. So that might be really, really rare events that happen post-operatively that you want to, you know, exclude, that when that happens, they're high cost, the person's in the hospital for 180 days and then dies. Those kind of clinical conditions you'd like to exclude. The other side, though, is that you want to include risk. You want to be able to have risk factors and conditions that are either amenable to mitigation by your teams preoperatively in the hospital, post-discharge, but that will increase the financial opportunity in the case. So you're now coming into a negotiation with a payer. Believe it or not, they're challenged. Sometimes these can seem to be like really one-sided, and they are somewhat. But they do have limited data sharing capability, and I have a little bit of sympathy having come from the private payer sector as well. You know, they've got contracts with other entities like post-acute providers and doctors, and there's things in those contracts about sharing data. So when they say, well, we can't share any data about any of the long-term care facilities that are in our network, they probably have contractual reasons for not doing that. That said, you're going to keep asking for it anyway. They're also limited, as I touched on earlier, by their current infrastructure. Most of these things, because they're retrospective, they can't differentiate complications from risk factors. So again, they're looking at your claims. They're looking that things are coded. So if you look at coding, anemia, for instance, could be preoperative, it could be a postoperative complication. And there's some ways that we use to differentiate it based on present on admission indicators, but in general, that's not part of what the health plans do. In addition, they use technology. And I just used ETGs as an example, episode treatment groupers. They were designed for something different other than risk stratification. And it's a way for them to get there. And this is part of the reason they may say your patients aren't as risky as you believe they are, because they're using a different methodology and technology to determine risk. They also have the issue that they may only have a few cases at your facility, and I think CJR is going to be one of the things that's going to inform us on this, because you may not have that many cases that are in their network. So when they go to give you data, how do you draw a conclusion on it? You know, it's a small number of cases when you're, as opposed to looking at the entire Medicare set. The other thing that I will caution against is the Medicare performance measurement being driven by star ratings and NCQA. Who believes star ratings are accurate? That was a fixed question. I knew the answer. I knew what you were going to say. The fact is, these are being used, and they're certainly being used in CJR down the, in the out years, where you can get a waiver on your 3-day rule if you admit to 3-star SNFs. We've done some work in one state where we looked at star ratings and quality and adverse outcomes in surgery, and it's in very few instances where the star rating helped us predict who was going to have adverse outcomes, at least at the high end. You might say maybe 1 stars, but when you start to try to differentiate between 2 and 4 or 3 and 4, those differentiations tend to fall down. So be careful about that. And I know the hospitals are going to be, Medicare just released their methodology regarding how they're going to rate hospitals, and I didn't get up early enough to read it, but I'll read it later. So touching a little bit more on this data asymmetry, they may have data on your competitors in the market, and everybody finds that valuable. They will have data on post-acute care because they've been paying for those services. They know about leakage. One study that came out of Johns Hopkins recently in looking at patients in a bundle, 20 to 40% of them got readmitted at a facility outside the hospital where they were operated on. So that, if you've got SNFs 60 miles away, 20 miles away, family wants them far away, you're going to have to figure out how, when they do have a problem, they get back to your facility and not the facility I'm staffing, where I'm going to do a big workup. I don't have their record. I don't have their doctor. They're going to be admitted, and that cost is going to go against your bundle. So think about emergency department costs, or I could even admit them to observation and then transfer them the next day and get a private ambulance involved. So start to think about, the cost associated with that. That's not been part of our thoughts really up to this point, but now with the more comprehensive bundles, those costs are included because they're outpatient costs. They also know readmissions across all facilities. I won't go much more into that. Now, on the provider side, we've got better internal data, and do not underestimate the data that you have available through your cost accounting systems, the things that you send out your bills on. You know what your internal costs are. We've worked with systems to determine which values and which things to put together so that you can get a better picture, a better retrospective picture of the 4 or 5 years of data that you have related to this. You probably don't have PAC data, post-acute care data, unless you own those entities, and if you do, that's great. You don't have a lot of information about data leakage. You also have costs for contracted services that, and private payers are starting to leverage this. I mean, one of the ways that they can approach you with a bundle is to say, you know what, we're going to let those people bill their fee-for-service claims, the emergency doctors, your employed physicians, your pathologists, your anesthesiologists, your IS, your hospitalists, your SNFs, not your SNFs, go down the list. But we're not going to pay them. We're going to give you a check for all of them, and then you're going to subdivide it. And who wants to be in the executive committee meeting when we make that decision? I don't have the slide here, but I actually have one of a tomato fight in Spain with everybody covered in tomatoes. It's an amazing photo. But the idea that, and I'm working with my own specialty at this point, to try to figure out how much value any one specialty brings to a bundle is a critical activity within your facilities. Because when you get to a point where they're saying, you know what, you've got contracts, leverage your own contracts, let them, pass the risk along to them. Have them change how they admit. Have them change those things. You have to be able to go and leverage those contracts. And I know that, at least I've talked to a couple of organizations that work with emergency department groups, and these language is beginning to show up in their contracts. Not necessarily with rates or contract guarantees or financial numbers, but it is starting to show up. So when you go into the negotiation, there's this asymmetry, which we've all felt. You've got a history of working with, or they insure your own employees. Some hospitals are self-insured, others are not. But if you're in a negotiation with the company, say Blue Cross or United, who insures your own employees, it's kind of hard to walk away from that insurance over a bundled payment negotiation. I'm sure anyone who's been in those negotiations would agree to go out and tell your employees you no longer have Blue Cross of whatever state because we couldn't come to an agreement with them on a bundled payment. So there's this asymmetry that's going on. What a third party can do for you is do an analysis on both sets of data. Bring that data together. Keep it separate, but to look at that, to really determine what's going on with your patients. How risky is your population? What is the experience? What are the levers you need to pull from their perspective and your perspective? And it gives you an equal playing field for the negotiation. It also allows you to analyze your cost improvement and look at metrics tied to adverse outcomes. And I'll touch upon this a little bit later, but this is critical for all of us to do. So again, third party can look at both sets of data and then give you a shared understanding to support that negotiation. I want to just illustrate one specific scenario that we've built, and again, this is for illustrative purposes only. It's CABG data, and as I mentioned earlier, we work with Medicare data, and we have permission under their rules to share some of the work that we do because of our research arm within our organization. So we also see tiering where people want to say, okay, if you have no complications or no comorbidities, you're in tier 1. You've got pick 3 of any one category, you're in tier 2. And if you pick 5, you end up in tier 3. Probably not the best way to do it because 3s and 5, what's in those categories interact and change. So within the model that we've developed, you see a case 1 with a 65-year-old without risk factors. So this would be your healthiest, best scenario case. You've got a budget for routine care. That's going to be your base evidence-based care. But within that warranty, you've got a little room for doctor variation. Some may use a certain medication, or some may use a specific dressing, or there may be some differences in how they treat patients. You don't want to get into standardizing all the way down to that level. You want to leave some room for judgment and the art of medicine, if you will. And you'll see as this goes up, the warranty associated with this, certainly there's an increase in the rate related to the budgeted care, but the warranty also provides you with the ability to use within your own system those things that either are appropriate to the patient or that you have expertise in using. This hasn't been mentioned, at least in the sessions that I've attended, and one of the, if any of you have ever done cost improvement, very rarely does an insurer ever pay for the cost of the cost improvement. Has anyone gotten a check for all of this work? No. So in addition to that, there's also the penalty if you spend all of your time improving your internal care processes, and this is relevant to where you want to focus. So if you want to spend all your time on acute care, what can happen is a DRG shift. So you're going to take people, and you're going to see people that are in, and we'll talk about joint replacements, that are in the 470 category, the fewer complications, if you will. You can see patients shifting out of one category into the other. They're better. So you're going to get penalized in your DRG payments as you improve your care. And that needs to be factored into your equation. You have to know which patients you're targeting, and you have to look at the financial ramifications from a DRG perspective for improving the care. Because not only do you have the care improvement costs, you may get a little bit back from CMS in year 3 or 4 if you hit the quality targets, but this is real, and this is going to happen right away. Other things to think about metrics. There's all the CMS metrics. I helped create the PQRI program, and I'm embarrassed about where it's gone. Of course, it was great when I was there. They've just not done well with it since. But I had to say that today, not yesterday when Rick was here, because he's still there. But focus on the things that you can measure and that really matter. Things like death. Comment about the 30 to 90 days. Most of us don't know what happens to our patients, even 30 days out. but we've done some national studies that are that are either in press or in publication that really identifies that, how many readmissions happen in the 30 to 90 day period in deaths, and that the post-discharge, there are more outpatient deaths after these procedures, certain procedures, and I'll use colons, for example, than there are on the inpatient side. And doctors are aghast, because we only think about, did they die in the hospital? For us, it's a success if they got discharged, and that's no longer the case. So you have to look at your death across the 90 days. And again, how many of you know how many of your patients die within 90 days in any product line? It's important, right? How do you know? You track it, okay. Emergency department visits, I could spend hours, and I do spend hours talking about this, and I'll spend all day working on this tomorrow. But my pen can create all kinds of spending. MRI, CT, you name it, not underutilization management. Admission, discharge, observation, admission. Lots of costs associated. I can call as many consults as I want generally. Nobody's really been monitoring me to date. So when you start, you have to think about those visits and how to optimize the discharge management after ED visits. It's not just about prevention. Your bundle's at risk based on when they do show up, and patients show up for multiple different reasons, and you have to manage that. And short stay transfers to skilled nursing facilities. We've done some work that, again, you can discharge them a day early. Yeah, it works on the DRG side, but if your readmission rates go up because of that, it's not worth it. So as our prior speaker said, sometimes you want to keep them in a hospital an extra day. That's an anathema in our current model of hospitalists, who actually have sometimes targets about limiting DRG days, right? So you're going to have a group of patients. You need to be able to evaluate who will do better if they have one additional day in the hospital. Ongoing monitoring. Again, I mentioned you're doing care redesign. You're changing all kinds of things at the same time. And when you change all those things, you end up with the question, so what really worked and what didn't? And in fact, probably 80% of what we put in place didn't impact the change. I mean, that's the Pareto kind of principle. But the fact is, you need to figure that out. You're spending a lot of money to change things, so you're going to need more money to change more things, and you're not going to get increased fees. So you're going to have to go back and look and say what worked that we did. One of the areas that we've done work in and continue to perfect or to enhance is using statistical process control, Schuhart's methodology, for linking costs and adverse outcomes. So again, normally we measure quality over here. We're looking at financial metrics here. This is a way to do trending and to look at that. So on your left, you'll see a chart about inpatient adverse outcomes. And what we do for people is we'll look at something that was implemented, a care redesign activity. And then we'll begin to track quarterly, monthly, depending on how much data you have, how many cases you have, when you seem to have outliers. And why this is important, it's because you want to be able to go back and find out why they were outliers. First of all, you have to identify them from an adverse outcome perspective. But we actually do chart reviews. I'm an informaticist, and I would love to get reports out of Epic that help me do this. In fact, I have to go in and look at the charts. And we all still have teams that do that, right? And if you want to talk about EHRs, that's a whole nother talk as well. But the idea is that, there's a lot of insights you gain about things like, and you all know this, the family couldn't make up their mind regarding which long-term care facility, or they didn't have a bed and they stayed another day. Anyone encounter that? Ever happen in your facilities? Yeah. Daughter lives far away and your care management team's not aware of them. So I think, it's pretty simple things that can drive these. On the other hand, we've seen patients coming in who have low hemoglobins and are then, proceed to surgery, and by the way, they're discharged with a hemoglobin of 8. And sometimes you need to keep them in to evaluate their gait and their steadiness because they're high risk to go home and fall. So again, looking at those outliers. When we look at cost outliers, this I think is really one of the areas that I'm very interested in, because you begin to do this at the physician level. You can do this if you have enough volume, the orthopedic surgeon level, for instance, and look at trends. So when you have a set of cases where you see one surgeon's trend going up over time, and you go in and look and say, wow, he just adopted a new joint replacement because there is innovation going on, or he's using 2 new screws, or he changed the dressing he's using. And you can manage those things, but we do continue to innovate. And or else you can say he may just be having more costly patients. But this has to be risk adjusted, and you have to recognize that if you're going to define outliers, You need to do it in a very systematic level over time in order to inform your practices. Other things to think about related to the private payers, certainly emergency medicine, hospitalists, these are the hospital-based physicians. Evaluate your need for surgical pathology in some of your joint replacements. I don't do that work, but you're sending the bone down so they can say it's bone. Not sure if that's of value. So those are things that you want to take a look at, but that you will find that private payers are going to say, you have contracts with these people or you have employed physicians, go manage, let them manage costs for you. Another area of important focus is on appropriate care, site of care selection. So you can, there's a first site of care selection, not necessarily on these, and we think about inpatient, outpatient, ambulatory surgical center, and that's a different conversation. But reassessing risk at the time of discharge for placement in a more systematic and formal way, I think is quite valuable. As we've done some work that looked at, total hip discharges to home health agencies, and you can see that there are patients at a higher risk for post-acute adverse outcomes who were discharged home rather than through HHA. And the hospital said, well, wait a minute, everybody gets HHA. They're all getting services. And we went back into the claims and found out that many of them didn't. Family didn't want them, they didn't answer the door. The husband sent them away. There's all kinds, you're shaking your head. So don't make the assumption because you wrote the order that these things are going to happen. And so, the abyss that can be the home is an area that you really have to monitor. And this also came into the fact that when we looked at day of the week discharges, and this is important when you're evaluating your home health providers, and you can use this with, talking to your payers, that, they get batched up, just like this process, right? They get really busy by the end of the week. You have block time. You're doing your patients all week. Sometimes they don't see the patients for 2 or 3 days after they're discharged. Anybody aware of how often that happens in your systems? Yeah. So again, we can't just assume that shifting site of care, you can't take that into look at it in isolation. So let's say you've got an 80-year-old, multiple comorbidities, and they're just on the line about, can we send them to home health or do they have to go to a SNF? Well, maybe the better part of valor there is to keep them in the hospital for a day, and we'll say it's a Saturday as opposed to a Friday, so that when they do go out, that those services are available. So just in conclusion, I think there are some important things when you're talking to your payers. Again, push for the data. Think about using external third parties with expertise in this area. Your population's not static. Even in ACOs, there's a churn of about 20 to 40% of patients. So assuming that CMS's risk adjustment or ABCD private payer risk adjustment is enough to help you through negotiations, maybe a short-sighted assumption to make, and ensure that you are thinking about that as a dynamic process, because again, your population's going to change, and if you're trying to bring in more volume, your population changes. If you're limiting patients now, you're taking certain patients out because you're delaying their care, your profiles are going to change as well. So it's really critical to think about risk adjustment and this at the highest level. And I'll close by making a prediction. I really believe that the private sector is going to far outpace Medicare here. Anyone participating in ACOs? So there's even an organization that pushes back at CMS, and they've been pretty successful at putting off the downside risk. And every time they get close to the downside risk, CMS kind of relents and comes out with a new model. Now there's the next generation ACO because they really didn't want to or didn't feel they could push. And so your private payers who are going to, are a source of significant volume, not just in commercial, but Medicare Advantage and the ever-increasing Medicaid population are going to move more quickly. Part of that is because they're publicly traded in many cases. The other is they are much more aggressive in negotiating, and they don't have Congress back here or the senator whose wife got sent home a week early or a day early. So really put some thought into your private payer strategy. A lot more to think about this, and if anyone has any questions, I'll be around today as well. And I appreciate your attention, and also your insights will be really helpful after this presentation. Thank you.
We have
Yeah,
Do you think, the question is, do you think there's going to be a readjustment or a standardization of risk adjustment?
I think everyone recognizes the shortcomings. Even CMS is changing the DRG system. Anyone who monitors what they're doing with DRGs, they're changing it to make it more bundle-friendly. So I don't think they're going to walk away from, DRG-based bundle payments and the things that go with it. Thus far, we've seen payers recognize that they have limitations in what they're doing, and people are beginning to recognize that if the provider and the payer in these negotiations doesn't agree on the population risk, you're not going to have a long-term bundle succeed. So I think you're going to see it happen on an incremental basis by different payers. They're maybe grudgingly, but again, as I mentioned, they're using claims, and a lot of the Medicare Advantage plans just got dinged by CMS because they were sending people out into the home to do risk assessments, and they were actually bumping people up into higher risk tiers so they could get additional dollars. And so it's an area that's going to continue to evolve, but I don't see any national agreement. And that's probably good for us because we practice locally. I really think it needs to be determined as much as it can within your own system for the population you're treating.
Okay. One more?
I was just going to ask, are there particular pockets or types of payers that you're seeing that are moving in this direction more quickly than others?
Yeah, we know of at least two of the major ones we've been involved with. And again, they're national payers. They are aggressively, in one case very aggressively, putting forth alternative prospective payment models. Others are being a little bit more tentative. But it is happening sporadically, and I think some cases they're starting with their centers of excellence. They've already got a center of excellence agreement, which is sort of a bundle, or case-based rate, if you will, and that's where we're starting to see it. But it's happening with all of them that we're aware of.
And the question was, are there any
sorry.
payers that are moving more quickly in this space than others? Susan, thank you very much.
You're welcome.
And thank you.